Uh, we are doing various different types of grips, and we are doing a few topics about what do you call? Hmm. Yeah, we are doing fundal grip, which is examination is done. Okay, so let's go on. I don't think I'll be able to teach everything. I know for a fact that I'm going to do until here, and I'll do normal labor, normal vomiting in pregnancy and all. So a few topics I'll do from here, but a big chunk of the topics I may not be able to do today. But yeah, let's see how it happens. Examination is done while facing the patient's face. So broad, soft, irregular mass suggestive of pitch, smooth, hard and globular mass suggestive of head. In transverse lie, neither of the fetal poles are palpated in the frontal area. So lateral or umbilical grip examination is done while facing the patient's face. Hands are placed flat on either side of the umbilicus. Palpate back, which is smooth, curved and resistant feel. Lumbar side is comparatively empty and there are small knob like irregular parts. Anterior shoulder, you have well marked prominence in the lower part of the uterus above the head. So lateral or umbilical grip examination is done when seeing the face. Either side of the umbilicus you have to palpate. Back you'll find smooth, curved and resistant feel. So lumbar side, limb side it is empty and there are small knob-like irregularities. Anterior shoulder you have marked prominence in the lower part of the uterus above the head. Then you have Pavlik grip, which is examination done while facing the patient's face. You face the patient's face and you do the examination. Overstretch the thumb and four fingers of the right hand placed over the lower pole of the uterus, keeping the ulnar border of the palm on the upper border of the pubic symphysis. So, Pavlik grip, this is the Pavlik grip, of course. When fingers and thumb are approximated, presenting part is grasped distinctively if not engaged, and also the mobility from side to side is tested. In transverse lie, Pavlik's grip is empty. It will be empty. Pelvic grip, it is done while facing the patient's feet. This is the only thing which is done while facing the patient's feet. Everything else, patient's face. Four fingers of the placed on either side of the midline in the lower pole of the uterus and parallel to the inguinal ligament. Lower pole parallel to inguinal ligament. The fingers are pressed downward and backward. Palpate the part occupying the lower uterus. If the head is a presenting part, then you can see the precise presenting area, attitude and engagement. Then fetal skull and maternal pelvis. So we have sutures. We have sagittal or longitudinal suture between two parietal bones. Coronal suture or what do you say? Coronal suture between parietal and frontal. Then frontal suture between the frontal bone. Lambdoid suture separating the occiput bone and the parietal bones, as we can see here. Then we have importance. It allows gliding movements of one bone over the other, which is called molding. It causes small variation in shape of fetal head necessary to negotiate maternal pelvis in order for the fetus to pass the maternal pelvis. Digital palpation of sagittal suture during labor. Information regarding the internal rotation of the head and manner of engagement, synclism or asynclism can be found out. So molding, altered shape of forecoming head while passing through the resistant birth canal during labor. There are three grading: 1, 2 and 3. 1, the both bones will touch but not overlap. 2 is bones will overlap but are easily separated. 3, there is fixed overlapping. And this is the images. You have the diameters of this skull. You have to remember 14.5. Not 14 maybe. 14 is enough. 14 centimeter is the biggest diameter. Smallest is 9.5. Okay. Smallest is suboccipitofrontal, mental, suboccipitobrachmic, and you have mentovertebral, submental vertebral, and OF, occipitofrontal. So, the most easiest methods of coming is submentobrachmic and suboccipitofrontal. It is a well flexed head. So subocciput of no sorry subocciput of Brigmic. Subocciput of Brigmic, which is 14.5. Submental Brigmic is also 9.4 centimeter only diameter. So face presentation will come with submental Brigmic. And yeah, so subocciput of Brigmic is 9.5. Biggest is mental vertical, which is 14. Okay, the values are given here. You have to remember this word. Subocciput of Brigmic, submental vertical is 14, and submental Brigmic in complete extension, face position. It is okay. Bro is the very bad position, and vertex is anyway okay. Transverse diameters, you have bimastoid diameter 7.5, bitemporal is 8, subparietal in 8.5, 9.5. Like that, it keeps on going. Caput is localized swelling of scalp due to effusion above the periosteum. It depends upon the position of the head, present at the birth, and disappears by 24 to 36 weeks. Size indicates amount of pressure on the head. Pathologically, you have obstruction of venous and lymphatic return due to pressure by cervix. You will have stagnation of fluid will be there due to obstruction of venous and lymphatic flow. Then there is edema of the scalp. This is what happens. Then cephalohematoma. There is sharply circumscribed, diffuse. Cephalohematoma is sharply circumcised. It is soft but pit on pressure. It is under the periosteum, does not cross the suture line. It is fixed to one place, may be associated with fracture, and it appears after birth, disappears after weeks or months. Caput sexism is diffuse. There is soft and pits on pressure. It is above the periosteum. It lies over the suture and crosses the suture lines and midline, and it is movable over the dependent part. It is not associated with fracture. It is soft and pits on suture, but it does in this one. Cephalohematoma does not pit. It is diffuse and it is sharp. It is under the periosteum. It is over the periosteum. Does not cross the suture line. Crosses the suture line. Fixed to one place, movable over dependent area, not associated with fracture. Associated with fracture. Appears after birth. Disappears after weeks or month. Appears after birth. Disappears after 24 to 34 weeks. 36 hours. Then pelvic inlet. It is round in shape, narrowest in AP diameter, widest in transverse dimension. Angle of inclination is the plane of the pelvic inlet, aka superior straight is tilted forward 55 degree with horizontal. So radiographically it is measured by measuring angle between frontal vertebra L5 and pelvic inlet and subtracting this from 180 degrees. So increase in angle of inclination, high inclination leads to damage in delayed engagement and descent of head. Then diameters of pelvic inlet. You have AP diameter, you have true conjugate or anatomical conjugate. So true conjugate or anatomical conjugate, true conjugate, it is measured from midpoint of the sacral promontory to upper border of pubic symphysis. Sacrum promontory to the upper border of pubic symphysis. Then you have obstetric conjugate, which is 10 to 10.5 centimeter. It is the most important. Fetus must pass through this diameter. Smallest anterior posterior diameter is there, and it is measured from symphysis pubis to middle of sacral promontory. Then pelvic inlet is considered contracted if obstetric conjugate is less than 10 cm. Cannot be measured clinically, estimated by subtracting 1.5 from diagonal conjugate. Okay, so first of all you need true conjugate. True conjugate, midpoint of the sacral promontory to the upper border of pubic symphysis. This is obstetric conjugate, which is estimated by subtracting 1.5 from diagonal conjugate. Okay, diagonal conjugate is measured from tip of sacral promontory to lower border of pubic symphysis. Okay, obstetric conjugate is the smallest AP diameter measured from pubic symphysis to middle of sacral promontory, but either way you cannot find out. So instead they just do subtract 1.5 from the tip of sacral promontory to the lower border of pubic symphysis. Only diagonal conjugate can be assessed clinically during late pregnancy or at the time of labor. No other conjugate can be calculated. Yeah. I don't have any good photos here, unfortunately. Okay, transverse diameter is this one right here. Transverse diameter is between the furthest 2 points on the iliopectineal line. Largest diameter of the pelvic inlet. 4 cm anterior to the promontory, 7 cm behind the UB symphysis. This is 7, this is 4. Okay. Fine. Oblique diameter is right and left oblique is there. Right oblique diameter passes from right sacroiliac joint to left iliopubic eminence. Left oblique diameter is from what do you say? From left sacroiliac joint to right iliopubic eminence. Okay. Sacroiliac joint to opposite side iliopubic. Okay. Then you have pelvic inlet. So boundaries of pelvic inlet, you have anterior, lateral and posterior. Anterior is lower margin of pubic symphysis. Lateral is descending ramus of pubic bone, ischial tuberosity, sacrotuberous ligament, and posterior is last piece of the sacrum. Diameter, you have AP diameter which is 13.5 cm, and you have transverse diameter which is 11 cm. Transverse diameter is widest. Transverse is widest diameter at pelvic inlet. AP is widest diameter at pelvic outlet. AP is more in pelvic outlet. Transverse is more in pelvic inlet. So you can remember it like this: in, out. Then fetal head must rotate from a transverse to AP position as it passes through the pelvis. This happens in mid pelvis where transverse and AP diameter are similar. In mid pelvis it is circle. Okay. So pelvic axis, it is a imaginary curved line. It is the path that the center of fetus head must take during its passage through the pelvis, from entry at the inlet to rotation in mid pelvis and exit at the outlet. Okay. Pelvic axis, that is the pelvic axis. Then antenatal care, preconceptual counseling and care. Okay. Antenatal care is systematic supervision of a woman during pregnancy. It is a care in continuum that starts before pregnancy, ends at delivery and postpartum period. Antenatal care comprises of careful history taking and examination, general and obstetrician. Advice is given to the pregnant woman. So aim is screen high risk cases, prevent and treat complication, ensure continuous risk assessment, educate mother, physiotherapy of the mother and labor, discuss and time, place, mode of delivery, and motivate family planning. Okay, all of this needs to be done in INC. Ensure normal pregnancy and delivery of every baby from healthy mother. Okay, criteria: you have delivery of a single baby, good condition at term, fetal weight 2.5 kg or more, no maternal complication. Those are the criteria. So at first visit should be before the second missed period. Before the second period happens, they have to come for first surgery. Assess the health status, assess the fetal gestational age, baseline investigations you have to do, organize continued obstetric care and risk assessment. So history, you have vital statistic, you have name, age, address, extremities of age, teenage and elderly are obstetric risk factors. Duration of marriage, religion, occupation of the husband, chief complaints, HOP, history of presenting pregnancy like hyperemesis, pyelitis, anemia, number of previous antenatal visits, immunization status, and medication of radiation exposure. Then obstetric history, you can check out gravida and para. The gravida means present and past pregnancy irrespective of gestational period. Para means state of previous pregnancy beyond period of viability. Gravida and para refers to pregnancies and not to babies. Woman who delivers twins in pregnancy is still considered G1 and P1. Okay, pregnancies, not the babies. Then P, A plus B plus C plus D, which is number of term pregnancies is A, number of preterm B, number of miscarriage C, and number of alive patient children alive at present is D. Gravida is multipara. Pregnant woman with previous history of more than 4 births is grand multipara. 5 or more births, we remember it as. Okay. Terminology is nullipara is never had conception leading period of viability. Nulligravida has never been pregnant. Primipara is one viable child. Primigravida is first time pregnant for the first time. Multigravida is previous pregnancy. Multipara is more than 2 pregnancy passing the stage of viability. Parturient is woman in labor, and prepura is who has just given birth. So menstrual history, period of gestation, LMP and EDD needs to be asked. Then none of these are important. You can ask them if you want these things. GP you have to do. Then vitals you have to check. CVS, breast, if nipples are cracked or depressed, skin condition of areola needs to be checked. Abdomen you have to do. Tone of abdomen, incisional scar, hernia, fundus palpable. Okay. Then vaginal, empty air bladder, lithotomy position, separating the labium, speculum examination by manual, 2 fingers, index and middle, separating the labia, introduce deep into the vagina. Okay. Left hand, suprapubically, genital examination, cervix you have to know, uterus you have to know, adnexia, consistency, direction and pathology, uterus size, shape, position, consistency, adnexia, any mass fell through the phonics. Then routine investigation, blood, serology, urine and cervical cytology. Then you have special investigation, serological tests for rubella, hepatitis B and HIV. With genetic screening you have maternal serum alpha fetoprotein, MSAFP. Triple test at 15 to 18 weeks for neural tube defects and Down syndrome. Then ultrasound examination, you have first trimester, early pregnancy, accurate dating, number of fetuses, gross fetal anatomy, uterine or adnexial pathology. Booking scan can be done at 18 to 20 weeks. Detailed fetal anatomy survey and placental localization can be done. Then further visits you can do once per month till 7 months, twice per month in 7th and 8th, and every week until delivery in the 9th month. So assess fetal well-being, anemia and preeclampsia, AFI also needs to be assessed, and diabetes needs to be assessed. Then abdominal examination you can do in 2nd trimester, quickening, external ballotment, palpation of a fetal part and auscultation of the fetal heart sound. In 3rd trimester you can do palpation, fetal lie, presentation, position, growth pattern, volume of liquor and girth of abdomen is to be measured by the level of umbilicus. Girth increases by about 2.5 cm per week beyond 30 weeks. Our terms measure about 95 to 100 cm. Then vaginal examination contraindicated if vaginal bleeding. So antenatal advice, increase calorie more than 300 kilocal. Normal BMI gain the optimum weight 11 kgs. Overweight limit weight 10 to 7 kg. More than 27 should gain very less. BMI more than 29 should gain very less weight. Supplementary nutrition therapy, all pregnant women from 16 weeks onward. More than 10 gram of hemoglobin, 1 tablet of ferrous sulfate, 60 mg of elemental should be provided. 60 mg of elemental iron, proportionally increasing with lower hemoglobin level, and supplementary vitamins to be given. Antenatal hygiene genuinely not required. Avoid strenuous work. Bed 10 hours. Constipation common. Plenty of fluid. Vegetables, milk, stool softener. Rectal bleeding, painful fistula, hemorrhage to hard stool. Take daily bath. Breast engorgement may be seen. Not restricted during pregnancy. Coitus is not restricted. Release of prostaglandins and oxytocin may cause uterine contraction. Increased risk of miscarriage or preterm should avoid coitus. Travel, venous stenosis, thromboembolism, long flight travel can be seen. IUGR, intrauterine growth restriction if smoking and alcohol is not controlled. Then unprotected women immunization you have to give. TD 6 weeks and the first dose is 16 to 24 weeks. Then after 6 weeks later. Women immunized in the past, you have to give booster dose 0.5 ml given in 3rd trimester. Warning signs of pregnancy: leakage of fluid, vaginal bleeding, abdominal pain, distressing in nature, headache, visual changes, disease or loss of fetal movements, fever, rigor, excessive vomiting, and diarrhea. Then I think, yeah, I will come back to these topics. Mm. And, yeah, and a lot of these topics you may require, they will ask questions. I'll come back to them. I need to do some other things first. I'll do them, and then if I'm having time, I'll do this onwards. Okay. Actually, give me a second. I'll be right back. 1 second. Mm. Okay, so give me a second. There are a few topics which I want to do. I think this is normal labor. Yeah. So I'll do from normal labor to I'll do normal labor full, normal preparum full, and I have several things here. I'll do normal labor till hemorrhage in early pregnancy 39. I'll do all this because hyperemesis is a very important question and normal labor is also a very important question. So normal labor is fine. Before we talk about normal labor, we have to talk about abnormal labor. Any deviation from definition of normal labor is abnormal labor, obviously. Then pre-labor is premonitory stage of labor. Begins 2 to 3 weeks before onset of true labor in primi gravida. Few days before in multipara. Okay. Associated with increase in oxytocin receptor in the myometrium. So, what are the changes which I've seen in pre-labor? You have lightening, descent of fetal head into pelvis, resulting in easier maternal breathing, and pelvic pressure will be less. Then cervical ripening will be there, softening of the cervix is there, and false labor pains will be seen. So, cervical changes. You have dilatation and effacement. In true labor it will be there, but in false labor it will not be there. Frequency of contraction will be regular and it will gradually increase. Or in false labor pain, it will be irregular. Pain will be in the lower abdomen and the back and it will be radiating. However, here the pain will only be in the lower abdomen. Bag of water will be formed in true labor. However, bag of water will not be formed in false labor. Show will be present, show will not be present, and anemia and sedation will not. In cases of true labor pain, it will not provide relief. Here, it will provide relief. Then, normal labor or eutosia. Normal labor is called normal if it fulfills the following criteria. First, it is a spontaneous in onset at term, with vertex presentation, without undue prolongation, natural termination with minimal aids, and without any complication. Health of the mother and baby normal. So that is normal labor. Mechanism: 3 steps occur simultaneously. Later 4 steps occur in order. Okay. So first 3 steps. Engagement will occur within movement of presenting part below the plane of the pelvic inlet. Movement of presenting part below the plane of filament. Descent is movement of presenting part down through this curve of birth canal. Flexion is placement of fetal chill on the thorax. Internal rotation is rotation of the position of the fetus head in mid pelvis from transverse to EP. Extension is movement of fetal chin away from the thorax. External rotation is rotation of fetal head outside the mother as the head passes through the pelvic outlet. Expulsion is delivery of the fetal shoulders and baby.
Onset of true labor is characterized by appearance of true labor pain and appearance of show. It is divided into four functional stages. Stage 1, you have cervical effacement and dilatation. Two phases it will be and divided into latent phase and active phase. Latent phase is less than 20 hours in primipara. It is less than 14 hours in multipara. Active phase is more than 0.7 centimeter per hour in primigravida and more than 1 centimeter per hour in multigravida. Fetal axis pressure in longitudinal lie and well-fitted flexed fetal head on cervix. Fetal vertebral column is straightened by the contraction of the uterus. Contractive force is transmitted through the vertebral column to the well-fitted fetal head. Causes mechanical stretching of lower segment and dilatation of the cervical canal. In transverse lie, fetal axis pressure is absent. Friedman's curve is pattern of cervical dilatation during labor, latent and active phase of normal labor. It is a sigmoid curve. And active phase subdivided into accelerated phase, phase of maximum slope, and deceleration phase. So accelerated phase is 3 to 4 centimeter of cervical dilatation. Maximum slope is 4 to 9 and deceleration phase is 9 to 10 centimeter. This is the cervical dilatation and level. Stage 2 is descent and delivery of the fetus. Maternal pushing effect are vitally important to uterine contractions to bring about descent of the fetal presenting part. So nulliparous woman, you have normal 1 hour. In the second stage will be prolonged without epidural anesthesia. With epidural anesthesia, it will lasting for 3 hours maximum. Okay. In multiparous, maximum normally it requires 30 minutes. Second stage it can be prolonged without epidural. It may last for 1 hour and 2 hours with epidural. So second stage arrest is when there is no change in descent of head for 1 hour more than prolonged. Then stage 3 is expulsion of placenta. It is myometrial contractions, searing of anchoring villi, usually augmented with IV oxytocin transfusion. So signs of stage 3, you have gush of blood vaginally, change of uterine shape to globular, lengthening of the umbilical cord, Kushner sign, which is pushing umbilical cephalad with hand on the abdomen and the cord no longer receding. Then management, you have expectant management. Placenta is separate and its descent into vagina is allowed to occur spontaneously. Duration it lasting for 15 minutes. Increased risk of bleeding, increased risk of BPH, and increased maternal mortality rate. Active management is placenta separation is actively facilitated. Powerful uterine contractions are initiated to reduce the incidence complications like postpartum hemorrhage, lasting for 5 minutes. Less bleeding is there, less chance of postpartum hemorrhage, and less maternal mortality is there. Active management includes administration of oxytocin, then delayed cord clamping, delivery of placenta by controlled cord traction, and uterine massage. All of these are active management of labor. Expectant manager, which is placental separation into descent into vagina allowed to occur spontaneously. Active management, you provide some support. Administration of oxytocin, delayed cord clamping, delivery by controlled cord traction, and uterine massage. Then stage 4, which is critical 2-hour period of close observation of parturient immediately after delivery. Vital signs and vaginal bleeding are monitored to recognize and treat preeclampsia and postpartum hemorrhage. Engagement, you have the greatest transverse diameter, biparietal diameter passed through the pelvic inlet. Then multipara, you have engagement occurs in late first stage after rupture of membranes. Nullipara, engagement occurs in last few weeks of pregnancy, 38 weeks. Engagement of head rules out cephalopelvic disproportion at the level of pelvic inlet. If head is engaged, it means head is at zero station. Engagement can be cyclic or acyclic. Sagittal suture of fetal head lies in transverse diameter of pelvic inlet, which is between SP and PS. Anterior is anterior parietal presentation and Naegele's obliquity. Sagittal suture is defected towards sacral promontory. Most common in multipara. Then posterior is Leedsman obliquity or posterior parietal presentation. Sagittal suture is deflected towards pubic symphysis and most common in nulliparous women. You have cyclic and acyclic. Acyclic is normal, I feel. I forget where I read. Some amount of acyclism is no problem. That's what I think I read. So causes of non-engagement is malpresentation, occipiter posterior, deflexed, cephalopelvic disproportion, placenta previa, tumors in lower segment, tumors of the fetal neck, cord around the neck, hydrocephalus, polyhydramnios and distended bladder and rectum. Cephalopelvic disproportion is a true cephalopelvic disproportion occurs when the presenting part of the fetus is too big or pelvis is too small. Pelvic dystocia. Pelvic dystocia is uncommon in developed countries but may occur after trauma. In developing countries, it is seen in vitamin D deficiency and rickets. Relative cephalopelvic disproportion is most common associated with fetal malposition, occipital posterior position or brow presentation. Management of labor stage 1. Abnormality of latent phase. You have prolonged latent phase, more than 20 hours in nullipara, more than 14 hours in multipara. Causation may be excessive sedation, epidural anesthesia, analgesia, poor cervical condition like thickened, uneffaced and undilated, false labor, most common in multipara. Diagnosis is observation of Redman's curve. Management, you have therapeutic rest, intramuscular morphine and oxytocin stimulation. Abnormalities of active phase, you have protracted active phase, which is arrest of dilatation, cessation of dilatation for more than 2 hours. Arrest of descent is cessation of descent for more than 1 hour. Diagnostic criteria for first stage labor arrest is latent phase has been completed and cervix is more than 4 cm dilated. Then uterine contraction pattern of more than 2000 millivolt units. In 10-minute period, present for 4 hours. And factors contributing to arrest and dilatation is excessive sedation, epidural analgesia, fetal malposition and cephalopelvic disproportion. Management, cephalopelvic disproportion is absent, you provide oxytocin. If it's present, you do cesarean section. Cephalopelvic disproportion is one of the most important reason for indication for cesarean section. Okay. Actually, okay, I'll continue from labor second stage after a bit, but let me just do this again. Asynclism understood. Cephalopelvic disproportion 2 is occurs when part of fetus is too big or pelvis is too small. Pelvic dystocia. Pelvic dystocia is uncommon in developed countries, but it may occur after trauma. In developing countries, it is seen in vitamin deficiency and rickets. Okay, relative is most common, associated with the fetal malposition, occipital posterior position or brow presentation. Okay. Management, abnormality of latent phase. If it is more than 20 hours in nullipara and more than 14 hours, then it is prolonged. Cause due to excessive sedation, analgesia, poor cervical condition like thick, uneffaced and undilated, and false labor, most commonly in multipara. Then diagnosis, you observe the Friedman curve. Management is therapeutic rest, and intramuscular 15 mg morphine and oxytocin stimulation. Abnormalities of active phase, you have protracted active phase, which is arrest of dilatation and cessation of dilatation for more than 2 hours, arrest of descent, cessation of descent for more than 1 hour. Diagnostic criteria of first stage of labor arrest is latent phase has been completed and cervix is more than 4 centimeter diameter dilated, and uterine contraction of more than 200 MV units in 10-minute period is for 4 hours. Then factors contributing to arrest and dilatation, you have excessive sedation, excessive analgesia, fetal malposition, cephalopelvic disproportion, and management is oxytocin or cesarean section. Okay. I'll do second stage of labor onwards after a little bit time. Okay.